If your sex is feeling different in your 30s, 40s, your desire dips, your dryness, your sleep swings, you're mad at your husband and you're not quite sure why, you're not broken, but there are some things that can help you feel more like you again. Hey guys, welcome back to Vaginally Speaking. Today, we're getting real about hormones, not as a buzzword, but as the system that shapes energy, mood, sex, sleep, and how we feel in our own bodies. My guest is Dr. Simran Rattan, a spirit-led, triple-boarded medical doctor and founded of Katar Health. She blends evidence-based hormone care with integrative medicine to help people live with more vitality, purpose, and joy. We'll talk perimenopause, desire, and the practical steps that actually move the needle. Plus, Dr. Rattan brought gifts, free resources to help you get started. So let's dive in. Welcome.
Hi, Allison. Thank you for having me on the show. It's great to be here.
Thank you. Thank you. Can you give a little bit about yourself and, what's all this magic and knowledge you're going to bring to us here on Vaginally Speaking today?
Yeah, sure. So, I started my career as everyone else into this conventional medicine field where I thought I was going to serve people in body, mind, and spirit. That was a bit of a rude awakening. What really happened was I was like, oh, we're really focusing on disease here. And what I had realized in my practice over the past 16 years of being a physician was that there was a missing component to health, and that was prevention and optimization of health. And I went into that integrative medicine. I completed my boards of integrative medicine from the United States, from the Andrew Weil Center of Integrative Medicine. I graduated from that. And one of the things I had learned there was that you have to look at a person as a whole, not just parts, because we're not a piece of a puzzle. We've got to look at the whole picture in order to see what is going on with a person. And an important part of that is hormones.
We are the puzzle is what I want to say. When you said we're not a piece, I want to be like, yeah, because we're the whole dang thing. We're the whole puzzle that we got to figure out. And there's different pieces to put together, including hormones that I said, it's kind of a buzzword right now. I feel like so many women are hearing, oh, do you know where your hormone level's at? What's your estrogen and your testosterone? What's going on? Do you have something going on with your thyroid? We hear these words and we don't know what they mean or what to do with them or what even to ask about when it comes to figuring out if there's something going on with our hormones. And, especially in our mid 30s to late 40s, we've got a huge shift that is just now really getting talked about, the perimenopausal women, right? For so long, I feel like we've just only heard of menopause, and these perimenopausal women are like having these symptoms and they're like, what's happening? I'm too young for menopause. It's not menopause. What's going on? So can you kind of explain a little bit of perimenopause and some of the changes that happen that may indicate hey, maybe it's time to go talk to your provider because, this is happening. I think of the stress and the changes in our sexual wellness and, the dryness in our vaginal health, the brain fog. There's so much, right? Ear itching. That was a big one for me of finding out that had to do with my hormones. So, yeah.
Yeah. And, I think with the perimenopause, what the biggest question I get is what you just said. What are my levels like? Is there supposed to be one test that tells me I'm in perimenopause? But the reality is that there isn't. There isn't one test to see that. Levels don't correlate with how you're going to feel in the perimenopausal stage, right? And so everyone's looking for what does my estrogen levels look like? What does my progesterone levels look like? Just exactly what you just said. But one of the problems with that is that as you go through perimenopause, your hormones are going up and down, up and down. Sometimes I just do this, as you guys know. They're going all over the place, but literally up and down, and you are not able to detect in blood that level at an accurate number because people could have one day really low levels of estrogen and then one day skyrocketed high levels of estrogen. And by testing it at one point and you think you're low, you might mistakenly think you're in post-menopause. So menopause is just one day where your 12 months goes by where you're not ovulating anymore. And so you no longer have a period. And then after that is postmenopause. So it's only one day, right? And so after 12 months. And so when women are going through perimenopause, it is the most frustrating time for a lot of women because they just don't feel quite right. They can't put their finger on it. Every symptom that they have is so vague. You know, they could be having, one of the biggest symptom is low energy. They can't understand, why do I feel so tired all the time? And as women, we kind of sometimes put this off as maybe we have children. If we have children, we're thinking it's the children. If we're working so hard, we blame it on work. We don't sometimes take that time to pause and figure out what's going on with me. Is there actually something going on? Is it physical? Is it mental? Most of the time it's both, right? And it's like, and you know, we just don't give that pause for ourselves. And so when we look at that perimenopausal phase, fatigue is a big one. And it's such a vague symptom. So I'm going to tell you, I was guilty when I first started medicine, when patients used to come and see me and say, hey, Dr. Rattan, I'm feeling really tired. And you know what I do? I check all their blood work. Everything was normal. But what I have learned that now is normal is not optimal health. And you can have normal levels, but not be optimized or not feel healthy at all. And so this is kind of what actually led me into this Andrew Weil program and doing the fellowship and getting my board certification, was because I really wanted to figure out other things in my tool belt, because I could clearly see on their face that they were not doing well. I had no idea what to do back in the day. Right. And then I started changing lifestyle, doing sleep, diet, exercise, helping women in that way. And there was still something that they didn't feel right. These women were doing everything right. They weren't losing the weight. They were still feeling exhausted. Their sleep was awful, like just awful, right? And so I was like, something's missing. And I delved into hormones actually back in my residency. And I did that here in Canada. And one of the things that I was shot down. I was really shot down by my attendees. They said, you know, you don't really do that until post-menopause. And I was like, oh, okay. But I remember reading this article on thyroid. No, we don't use thyroid unless you have a thyroid disease. I'm like, oh, okay. I was like, okay, that's fine. You know, I'm learning. So I had to just get through the system, right? And then I was told, like, we don't use hormones till post-menopause. And so all these women in perimenopause were not going to be looked at. And it was all because of this one trial, which you've probably heard about, the WHI trial that came out in 2001, 2002. And it basically pulled all the hormones off the shelf after that. And it was a scare of this whole breast cancer when the study wasn't even meant for breast cancer, right? And it was meant for cardiovascular. And even for cardiovascular, what they had found in the study was that it was not the estrogen that did that. It was something called progestins, which is very different than a progesterone, which is a bioidentical hormone, the hormone in your body. And we can make those bioidentical hormones now to match your body. Right. And so just by like looking at that, women in perimenopause were really left to suffer, which now it's coming out more that, hey, there's a solution to this, right? You are feeling joint pain. You are having no sleep anymore. Or your sleep is not great. You're noticing the weight changes. And this happens about 10 to 20 years before you even go to menopause. You're in this for at least 10 to 15 years. Yeah, even some women 20, right? So how do we help them? There's no test. I can tell you that now. There's no test, right, to do that. However, and the people do things like, I don't know if you've ever heard of like Dutch testing, which is urine. There's a whole bunch of tests that can tell you this is where my hormone levels are. The reality is that doesn't necessarily mean that just because you know that and then testing it again, it doesn't necessarily correlate with how you feel. And so I have patients who are younger, in their 30s, even in their 20s, but we'll get into 20s another, maybe later when I talk about PCOS a little bit, right? But basically the 30-year-olds who are starting to come to see me, they're the ones who are like, I feel awful, Dr. Rattan, and they're telling me I can't do anything about it. And I don't blame my colleagues, because we were not trained in medicine in this, right? We were not given women's health studies because they just didn't think about it. And the WHI trial came out, you know, when we were in school. So that was no longer taught in medical school, right? And so when the women are telling me I don't sleep well, I don't feel good, I'm just feeling exhausted, I start looking more at, yes, their symptoms, how they're feeling. I treat the person, not the numbers. And that's huge, because we in medicine, we're actually told to treat the person, but somehow along the system, we've been relying on looking at these labs, which then has now made the public rely on screening tests and labs without realizing that those are just going to tell you one point in time. So what I do is I do blood work just to kind of see where they're at baseline, in the sense that when I give you the hormone, I know you're absorbing it. And then I don't really have to keep testing it. I can tell that based on what you're feeling and how you're reacting to the hormone and how you're going. So some of these things, like, let's get into, I think, what you really want to get into. Let's talk about sex a little bit, right? Because this is one thing that women don't talk about. Right. And they don't talk about it in the office. So one thing that I do, and it's a bit funny, but I take the opportunity that when they're coming for their PAP, let's talk about sex a little bit. Right. And it's a bit weird. So I make sure that they're still clothed before we kind of get into it. I just, we're going to talk a little bit of some symptoms. And then when I actually go to look at their vaginal area, it's crazy how I would say, I think the stat is like 80 something percent. I'm sorry, I forget the exact number, but literally 80 something percent, 87, I think it is, something really high like that, that says to you that women have vaginal symptoms that are dryness, vaginal dryness, pain, irritation, just feeling burning down there. And they only 25% tell their doctor. Right.
But that doesn't surprise me, that number. I wouldn't have been surprised you would have told me it was 10%.
Yeah. And so people don't talk about this. And also, to be fair, some physicians may not ask about it, right? And that may not be because they don't care. It's because maybe we don't have the time, or we forgot, or what are we going to do about it? Because unfortunately, as we have been trained to think that if we give estrogen for vaginal symptoms, we're going to cause cancer. But the studies have shown that that is not true, that it doesn't cause cancer, and that estrogen is not important. It is an important part and does not increase your risk for breast cancer. Right? In fact, it's shown to decrease the risk. Right? And this is actually for both synthetic estrogen and bioidentical estrogen, not just one or the other. Now, the problem is the progestins. So the progestin is considered what is called synthetic. I don't like to say synthetic progesterone because I don't want to confuse the audience, because a lot of physicians change the word and interchange it as the same. So they say progesterone and then they start saying synthetic progesterone. It's really just progestins, right? They are molecularly structured, not the same. And the way to think about this is think about it as you're putting a key into the door. There's one that fits perfectly for that door, right? And you turn it, no issues. Then there's one that kind of fits, does open the lock, which is your receptors, and opens it, but you don't know what kind of damage it's going to do because of it not fully fitting in that door. So I think of synthetic as not fully matching the keyhole, right? And where bioidentical is matching it exactly to the same way as your hormone in your body is matching it, because it's identically structured the same way. Right. And so just by looking at that, understanding that progestins and progesterone are different, the increased risk of breast cancer comes from progestins, not from progesterone, which has been shown to be protective. Right. So let's get back into sex. Right. And so putting that back in there is that when the vaginal area changes, here's what happens. Women don't even notice that they can be getting this dryness starting at age 35 onwards, because the hormones start declining. And as they start declining, they start having irritability. They don't like their partner too much anymore. They want to tell them to get out of their face. There's all this like heated stuff. And it's interesting that like 69% of divorces are initiated by women. Right. And the ages are usually between 40 and 50. Work is affected in that as well. And relationships are so important because, yes, there's a high value on intimacy. So I'm a big fan, as you know, of mental and spiritual health and being able to connect to yourself and your partner. And of course, that's a part of your journey. Like, you need to do that. But there is this physical component that's really important for you having libido, right? There's maybe five things, or maybe four things that actually really affect a woman, besides mental. Of course, mental is number one, right? And number two is things like lubrication. Are they getting lubricated, right? Are they having the arousal, which is different than desire, right? So those are another ones. And are they also noticing they're having pain? So these five things can really influence how a woman is feeling with their sexual function. And the only way and can hormones help that? Absolutely. So estrogen supports the lubrication, right? It supports the blood flow and even the tissue, what's called elasticity as well. So that can bring it back. Testosterone can boost sexual desire, how many women are getting testosterone?
Not many.
Not many, right? It also helps with arousal, and it also helps with the intensity of your orgasm, right?
Mm.
Yeah. And I did actually forget that orgasm is one of those five, right? Besides the mental, right?
We do
So
like
are
those.
women, yeah. Yeah. And women are not orgasming. Again, sometimes it can be purely a physical and hormonal aspect to it, right?
Mm-hmm.
The other hormone that we don't think about often, because estrogen and testosterone are coming a lot more into the media, one hormone that I'm going to say that people are not really looking at as a sexual hormone, but I do, is progesterone. And it's not because I'm looking at these studies that say you use it lubrication, all that stuff, not for those, but because it works on something called GABA in your brain. And GABA is a relaxing hormone. It helps you, guess what? Sleep. So if you're sleeping better, you're going to feel less irritable in the day. And you may like your partner a bit better because it calms your nerves. It's your calming hormone. It helps you to feel less overwhelmed. And by calming the nervous system, that's going to help you to feel less, or maybe more connected actually with your partner, and less overwhelmed with the whole situation that's going on there, right? And so just having that feeling of safety with yourself is important first. And that doesn't happen if you don't feel like yourself.
Right, right. And I would say a huge thing that I always talk about is that we have to relax to be able to have an orgasm. So if we
Yes.
can't relax, we're not going to feel that estrogen and testosterone may be helping that arousal and the elasticity and the blood flow. But if we can't relax, we're not going to have it. That nervous system's in fight or flight. We're not getting good sleep. You know, it takes a team to have good sexual desire, connection, orgasm, right? Arousal and orgasm.
Yeah.
And so I love that you talked about that.
Adding to that too is like, I think we had a conversation a long time ago about this, was mainly more about like how a woman and how they feel inside their body is really important, right?
So important.
And so when your hormones decline, guess what happens? Your shape changes, right? And now you may not like yourself, or you don't want to show your body, right? And how are you feeling comfortable with inside your body? And that's a really important part of sexual well-being. And so they're like, I don't understand. I'm working out. I'm eating right. Well, I think, to be fair, eating right, I think, is a big, broad statement, because it's different for each person. Funny enough, we think it's always a one type of diet, but there is different diets that work for different people, right? But even with the eating, even if they're eating pretty clean, and which is just take out junk, I would say that, just take out the junk food, they still are not seeing these improvements in their body. And guess what hormone is also ignored? Thyroid. And thyroid brings your energy back, and it can help with your metabolism.
Yes. And I love that. I know you're going to go into it a little bit with the thyroid, but a huge thing that I think so many women and men as well, but are tired of, going to traditional medicine and hearing, right? Eat better, work out, sleep, you'll be good, right? Like we all know that we're going to be told that if we're not, in their category of weight or, built. So we're like, yeah, I know that. But like, what else? Or, to what you talk about, the energy, you're like, yeah, I know, but I have literally no energy to get up, or my body doesn't feel good. I know if I do these things that it will make me feel good, but then what if it doesn't? And I think that that's where, then people have desperately turned to different, less traditional medicine, because they're like, oh, they said they can run this Dutch test. They can do this saliva test. They're going to be able to tell me this, and this, and I'm going to be doing so good. And some people that works great. And then some people are still like, all right, cool. But like, I still don't feel good because you told me all my numbers are good. Right. And so you're like, what? Like, hell, and I will raise my hand. Dr. Sim and I have talked, like, this is me. But talk about the thyroid, because I think that's also like something that people are aware of, the thyroid having to do with metabolism, but not really having like what it fully has to do with. And, your thought process on optimal versus just in range in that particular hormone.
Yeah. So thyroid is probably the most complicated hormone, and yet it's also one of my favorite hormones. And the reason why I say that, it's complicated for us as physicians to think about it in a normal type of setting, because our normal is meaning that you're in a certain range of levels, right? Unfortunately, with that level, it's an average. It's an average of a age group of just, I'm going to give you arbitrary number, maybe from 40 to 60 or 40 to 80 years old, where and it can be that broad, by the way, right? And they take 100 people and they test their blood and then they average it out across and say, in these 100 people of all these different, this age group, this is their normal range. But as we age, those ranges get smaller and smaller and smaller. And so that's a problem, because then we're going to be only thinking about the number and not treating the person who has symptoms that sound like they have a low thyroid, right? Now, if you do have a thyroid problem, that's the other issue, is that we give medications that can help with that. One of them is that a specifically component of something called T4, which is your inactive hormone. And the other one is T4 and T3. And a lot of physicians, we were trained only to give T4 because it was shown to be beneficial and it relies on your thyroid to convert into T3. Some people have an issue converting, right? Some people have a genetic problem with converting too, and some people convert to something called reverse T3, which is also inactive. And the problem is T3 is your metabolic hormone, which means it goes into the tissue and works on something called mitochondria, which helps with energy of all your cells. And so when that happens, you're going to feel better if you get the T3 into your system. But some women don't have enough and they don't feel good, but their T4 is normal. And a lot of us as physicians do not check the T3 because, again, T3 could be normal. And even if it's normal, what are you going to do about it? So you could trial a little bit of thyroid that has both T4 and T3 in it and see if that helps with energy. But you'd have to find a provider who understands how to do that. And also if you actually need it, because it could be other symptoms that are causing it. Things like low, if you are in postmenopause, low estrogen, if you're in progesterone, testosterone, DHEA, these are all hormones that can help with that. And they can be taken. And a lot of people ask me, how do I take these? There's many different routes to take it. Estrogen can be taken. Well, you should be using it vaginally if you're having vaginal issues for sure. And you can be using it as well orally. And they have other ways of doing it as well. They can put it through a patch. And so those are depending on what you're trying to figure out for that patient. Right? When it comes to testosterone, you want to use it as a cream if you want the sexual benefits of it, and you want to do it more local to the vaginal area. And it also helps then with, guess what? Things like incontinence, which happens when women end up having children, right? Like they have incontinence, and this helps to bring back that mucosa, but also helps to decrease incontinence. There's some good studies that show that testosterone can help with that. Same thing with DHEA. It can be very good for the vaginal area as well. And it helps with the bringing back of the mucosa and as well as decreasing incontinence. Because all these things, guess what, affect you mentally when you're going to have sex. Because you're going to be like, ooh, what if I sneeze? Or what if I cough during sex? And it just spills, right? It's so embarrassing. And women are conscious about these things because I think anyone would be, right? Because it's not something fun to have that when you're in this intimate moment.
Right. And you should also see a pelvic floor therapist if you're having incontinence when you pee and cough and sneeze. But, so that's really good to know. So I'm going to be vulnerable and I'm going to say what I love is that I had all this lab work done and I went up and I said, okay, can you look at my lab work? And she says, yeah. And I said, okay, here it is. And she's like, okay, yeah. But it doesn't tell me anything. And I'm like, what do you mean it doesn't tell you anything? I've got these numbers right here. Like, why don't what do I need? She's like, well, these tell me you're in range, but are you optimal? I don't know, and I think that is just great because I do think that at some point we did stop thinking about treating the person and we got so fixated on numbers. And I tell patients, be it not even this, when I have patients come in for lactation and their child is losing weight and they're frustrated with what their physician said, I said, hey, here's the thing. We like numbers. Numbers tell us things. Numbers can help us show if things increased, decreased. I mean, physicians they're shown like that they need to meet certain numbers or that things need to go this way because then, we're on the right track. So I understand how their brain is going to that, but we can have plans in place while we're trying to do that, when it comes to lactation. But I love that you said that we have to treat the symptoms. And I've actually had a provider look at me and say, or treat the person. I've had a provider look at me and say, I just treat the symptoms and I don't look for the cause. And I was like, huh? What? Okay. So somebody is listening to this and they're like, where do I even start? Or like, how do I know that I'm fitting in this? I've got brain fog, or I've got super low energy. I feel dryness in my vaginal area. What would be like the baby step you would tell people? Because, or, the baby step, but also like for those people that just, there's so much information out there that can be a good thing, but it can also be a scary thing, because then we can just like have these things contraindicate each other and just like they don't make sense, right? And if you're not in the medical world or have colleagues or friends that are in the medical world that can explain it on a level that's understandable to you, it can feel really scary to get into it. So what would you tell people who are like, yeah, this is me, but I don't know where to even look?
Yeah, so it's a tough one. I agree with that, because you are relying on your doctor to hopefully know that this
Mm-hmm.
is what you need. And again, like I said, it's not our fault. We were not
Right.
trained in that. I mean, however, I just happened to want to go and figure out why was it happening. That was just my personality and the way I am. And so I wanted to kind of answer those questions for myself and for my patients. Like, why are they all coming to me? And I'm saying they're normal, but they're not. Right? And I can
Mm-hmm.
see that. And so that just made me figure out there's something else going on. And I kind of took that route. Now, what women can do is, when you're saying all those symptoms, if you're like age, I say 30, but they say 35 and everywhere else, that when you hit age 30, you actually decline, your hormones decline. So if you are getting those symptoms in your 30s onwards, you're already having a hormonal decline. Right. And so
Mm-hmm.
when that starts happening and you're having those symptoms, that you do need to talk to your doctor, or you need to look for a provider that understands hormones. So maybe a hormone expert. And I would say there's two ways to look at this. One is to help you improve your symptoms and the way you feel. The second thing is to help you to prevent disease. And so it's almost looking for doctors who specialize in both, not
Mm-hmm.
just the overall conventional care, right? And the reason why I say that is because as your hormones decline, and just to get to that second part, because we talked a lot about the first part, which are the symptoms, and they're so vague, they can be anything that's going on in your body, and you might not even realize that this is your hormone decline. Where the second part, prevention, when they start declining and your hormones are suboptimal, there are 5 things you're at risk for, right? Number 1 is insulin resistance. What does that mean? When you eat something, you have higher levels of insulin that spike up. And if you have too much high insulin for the very little amount that you're having, you are insulin resistant. And what I mean, you're having what you're eating, right? The second thing, when that starts happening, you have an increased risk for heart disease. Heart disease is the number 1 killer in all men and women, not just women. But women get missed for heart disease because all the studies were done on men. And so all the typical symptoms were of men, not of women. And so women get missed because they don't have the typical heart symptoms that they have. And so that's a really important thing as well. And then number 3 is your bone depletion. As you get older, you get something called osteoporosis. And that is a really important thing, because if you get osteoporosis, hip fractures, 70% end up in like hospitals. It's really horrible. And it's like you can even die from them, right? And so nobody realizes that the hip fractures can be quite a bad thing. And then number 4 is cognitive decline, which is what we were just talking about: energy, depression, anxiety. These are symptoms. You may not even think that you're depression. You're like, why am I hitting my 35s or 30s? I'm even 35, 36, 37. I'm like, I'm suddenly more anxious than usual. I am having depression. I never had it before. Or I always had underlying depression, but now it's even worse. Whatever it might be, this could be a hormonal change, right? And then that, if cognitive decline happens, and you can have an increased risk then also for things like Alzheimer and dementia because of that insulin resistance. And then the last thing that, I mean, there's so many more, but I'm just going to give you five. The last thing is that this is something called sarcopenia, which means low muscle mass. So as we age, we lose our muscle tremendously. And that's huge because it's important for our immunity. It's important for insulin resistance. When you have more muscle, you can get that into your muscle more, your sugar, and insulin is you don't need insulin to do that. Your muscles are the only ones that can actually increase your sensitivity to insulin, right? And so that's kind of where those five things. So when a person's looking for help, I would definitely try to find somebody who thinks a bit more outside the box. Not every provider will be perfect for you, so you may need to look at maybe multiple providers. And if you're having vaginal symptoms, the easy low-lying fruit is, hopefully physicians don't feel uncomfortable, and they do still, but find a physician, and that's an easy language too. If you're in the postmenopausal phase or even about to be postmenopause phase and you're having vaginal dryness, getting that vaginal estrogen is very safe.
Mm-hmm. Thank you for all of that. Now, you mentioned earlier in the show a little bit about PCOS, and I know you have a love for PCOS, and I believe we've talked about endo before, so correct me if I'm wrong about some endo with hormones. Those are common patients that I see, and I've been saying to my other colleagues, I don't know if we are becoming more aware of that pelvic floor can help with PCOS and endo, or if we are really having an influx in PCOS and endo patients, across the nation. So can you talk a little bit about PCOS, endo, and hormones?
Yeah, so PCOS and endometriosis is a commonly missed diagnosis, right? So you just doing even ultrasound, you may not even see it. So PCOS, only 50% of women, by the way, have the typical symptoms. PCOS is polycystic ovarian syndrome. It is a syndrome, not necessarily a disease, right? It's a cluster of symptoms put together. And the textbook type of picture is having acne, having hair loss, having hair growth on your face, and having missed periods. That's a textbook picture. But the reality is only 50% of women have acne. Only 50% of women have loss of hair, even though they don't, and actually some people don't even have irregular periods. And so this is how it's a very missed diagnosis, because what we really care about with PCOS is the fact that when you're PCOS, you are actually insulin resistant. And PCOS and insulin resistance go together. And insulin resistance, as we just briefly talked about, being the precursor to all chronic diseases, because it increases your risk for inflammation and then everything else that happens, cancers, heart disease, and brain cognitive issues like Alzheimer's, right? And dementia. So one of the things is that with PCOS, it is a hormonal one. Everyone thinks it's because their testosterone and their DHEA will be high, and that's a textbook picture. You may have high testosterone, high DHEA. This is blood work level. They'll check it, right? Right. And it doesn't mean it's actually that. If it's really skyrocketed high, fine. Okay. You might have some benefits there to see that, right? Especially if you're in your 30s, and some of my postmenopausal women are still not declined in their testosterone completely yet, right? But even when you look at those women, they look at the testosterone and the DHEA, and if those are high, then they say you have PCOS. If you have that plus acne or some other symptom, so two or three symptoms, right? But the problem is that women can have normal levels of testosterone, normal levels of DHEA, and still get the acne and hair, because they have sensitivity at the tissue and the hair that is a lot more sensitive at the receptors than people who do not, right, have PCOS. And so that's one thing with PCOS. So with PCOS, what we really want to look at there is helping them to, and everyone also, sorry, I'm just going to backtrack a little bit. Everyone thinks that you have to be overweight to be PCOS. You don't have to be overweight. There's something called fat on the organs. Insulin resistant is, when you have fat on the organs, you are insulin resistant. And when you have PCOS women who are thin, they may also be insulin resistant and actually have fat on the organs. So you might see like a fatty liver, even though they're thin, for example, right? So that's kind of where it's a misinterpretation. And that's a lot of the ones who are thin get missed because they think that they don't have the fat, and women and doctors don't think about it that way. And we don't look at it this. So I kind of say, like, I screen everyone for PCOS. In my head, you're PCOS until I prove you're not, right? So that's really what it is, right? And then with endometriosis, that's a little different. That one is more about like thickening in the lining, and these glands can also go outside the uterus. They don't actually necessarily always have to be in the uterus. It's a very, very painful. Women tend to notice that they're feeling pain, not just in their period, but also other times. It can be in their abdomen too, because this can move into the abdomen, and estrogen can feed it. So when they have estrogen, it ends up making it feel worse, right? It is, and the problem with this is, and this is just like going to take you off on a little tangent here a bit, but basically when you have endometriosis, this is kind of where I have this thing of like, why are we only treating women? Because a lot of women get hysterectomies if they have really bad endometriosis, if the ablations, which is like taking the lining down, don't work. And when they get the hysterectomy, then they get put on, if they're postmenopausal, they'll get put on estrogen. If they're still peri, they might be having the estrogen going up and down. But once the estrogen is gone, they get put on estrogen to help them if they get for HRT or PHRT. And the problem, though, is that endometriosis, we're assuming it's all out of the area, not just the uterus. It goes outside the uterus. And I still remember my mentor telling me a case that I was like, thank God I anyways give women progesterone, even if they have a hysterectomy, because of the benefits of progesterone on the brain, the breast, and the whole other tissues that we have, and the uterus as well. But if you don't have a uterus, it has effects on the brain as well, progesterone. Here's what happens. If you have a hysterectomy and you have endometriosis, and just say some of that tissue is still in the abdomen somewhere really tiny, and you keep feeding it, guess what? Estrogen. This thing's going to grow. What counteracts that? Progesterone. So all my patients get progesterone, because guess what's the most misdiagnosed? It's both, but they're not getting diagnosed. Endometriosis women are not getting diagnosed. Sometimes they don't even know why they got their uterus removed, right? And maybe their doctor told them, but they don't remember, right? They don't understand what they had, because they just told that they were bleeding a lot, time to get your uterus out, to get the uterus removed. It's a great tool to help with the quality of life, because bleeding sucks like all the time, right? But the reality is that I put my patients on the progesterone, especially if they had a history of endometriosis, even if they had a hysterectomy, because I want to make sure that they are not going to be feeding this when they're on HRT or BHRT with just estrogen. Right. And so this is a hard one for women when they are having, again, we'll go back to sex, because it's painful. Endometriosis is a painful disorder when you have it, or disease.
I mean, I say that endometriosis, those patients have so much psychosocial stuff that's very valid, but so much of that, when those patients come in, my heart sinks, because we know there's not a cure, but there's some things that we can do to minimize and help alleviate things. But I've had so many young people come in. There's been a huge uptick in people talking about quad pain, hamstring pain, that I'm like, wow, like that wasn't even a thought of mine at first when I was working with people. And yeah, it's just, I appreciate you being able to explain a little bit about the PCOS and endometriosis even more to people, because those individuals feel really lost, and our hormones play a huge role in that. And there is, hopefully there will be more research on finding ways to really decrease, if not eliminate, some of the challenges that come with it. But I'm glad
I think the non-surgical ways, they do have medications that block the estrogen receptors, which is fine. And some women need that. The only problem with that is that it doesn't just block it locally. So estrogen is really important for our bones, our brains, our heart. And so blocking estrogen, women don't usually feel well, the estrogen receptors with that. But, some women need it, and you might need to get it done. And then, when maybe they don't want the surgical option, there are those medical options that can help with that. Right.
Before we wrap up, is there anything you really want to make sure that the people listening know from you, or any, one thing that you want them to walk away with?
Yeah, I think the biggest thing is understanding that your symptoms don't necessarily correlate with your blood levels, right? And that normal isn't optimal, because you are every person is a snowflake, right? Everyone is different. And so that is one thing. And having a doctor who can look at you more in a whole person approach is really important. The body, the mind, and the soul, like helping you understand your meaning throughout the whole thing. And because as you shift in your age, you're going to need to figure out like why am I in this? Like what's going on? And you're trying to find meaning, right? So that's really important too. And I think like just to kind of help you out, I do have a free course on my website that is a simple hormone course. It's very simple, not like full of doctor jargon. It is a very simple course that you can kind of watch. It tells you more about the PCOS on there. It has like about thyroid, brain health, and also menopause. So you can kind of like look through that. And then I'm also gonna just to kind of evaluate where you are in your own health, because sometimes there's so much overwhelming information out there. I think I've given you guys a link to something called my Elevate Your Quality of Life. And really what it is trying to help you to assess yourself and figure out where you are in just your own health journey, helping you to figure out some goals for yourself and what you want for your health, and figure out your kind of why to be healthy a little bit. And so, download that, have a shot at that. It might help you just to kind of go through some of the symptoms. Do I have these symptoms? And they might be, your hormones declining from that.
Yes, I want to thank you for those resources, and everybody listening there in the show notes. So please check those out. If your sex is feeling different in your 30s, 40s, your desire dips, your dryness, your sleep swings, you're mad at your husband and you're not quite sure why, you're not broken. But there are some things that can help you feel more like you again. Hormones are talking to you. And today I want to thank Dr. Simran Rattan for coming on and talking to us and spreading all of the beautiful information and breaking it down to us that in a way that we can understand for everybody, because, medical information can be very overwhelming. It can be very hard to follow. And you made it so easy and beautiful. So thank you so much for coming on. I truly appreciate it.